We move on to the next presentation. This will be presented by a substitute, which is Wassim Bazzi, a multicenter comparison of intermediate oncologic outcomes of laparoscopic partial nephrectomy and renal cryoablation. This is from University of California, San Diego, and Tennessee and Memphis Health Science Center.
Dr. Silverstein, Dr. Scholl, thanks for giving me this opportunity to speak to the SAGES community and this morning. Dr. Derwish couldn't be here today, so this is our plan B per Dr. Smith. How do I go forward? Okay. So this is will be our topic for today, multi-center comparison of intermediate oncologic outcome, laparoscopic partial nephrectomy, and renal cryoablation. One of the surgical paradigms and dogmas in the current urology literature is small renal masses. Current definition of small renal masses is anything less than 4 centimeters in the greatest diameter. There's been many advances in the field of treating these tumors, especially because they can progress into eventually metastatic disease, even at this low volume if they were to be cancerous. One of the modalities that's been recently is the laparoscopic partial nephrectomy. And another modality that's been is also currently available and highly debatable in the literature, in the urology literature at least, is the renal cryoablation. Methods, this is a multi-center retrospective review of 123 laparoscopic partial nephrectomies and 119 renal cryoablation performed between September of 1998 till March of 2008. There were 4 centers participated in this review. University of California, San Diego, which is my home institution, University of Tennessee at Memphis, East Virginia Medical School, and the San Diego Naval Medical Center. Our laparoscopic partial nephrectomy were performed through a retroperitoneal or transperitoneal approach. Our renal cryoablation was performed either through a percutaneous approach in the interventional radiology suite or through a laparoscopic approach in the operating room. All patients had at least 6 months of follow-up postoperatively. The follow-up, our protocols consists of a physical examination, repeat lab values and renal function, and imaging at a regular interval. If a patient, when they return, if they still have a persistent enhancement in the area of cryoablation or in the area of the laparoscopic partial nephrectomy, that was considered to be a failure. In the case of renal cryoablation, one had repeated the biopsies of the area, and we did perform a repeat cryoablation of the area as well. Recorded data, demographics were recorded: age, gender, ethnicity, body mass index, history of hypertension, smoking, and diabetes. The tumor characteristics were recorded as well, the stage of the tumor as well as the pathology. Our outcomes were primary treatment failure and disease-specific survival and overall survival. Data analysis was performed with a t-test for continuous variables, chi-square for categorical variables, and p-value less than 0.05 was considered statistically significant. Table 1 is a patient demographics. When the laparoscopic partial nephrectomy group is compared to renal cryo group, our data is consistent with that literature, but our patients were actually significantly younger. There is no significant difference in terms of gender, race, mean body mass index. Sorry, there was a difference in the mean body, renal cryoablation was slightly larger, sorry. Diabetes was not significantly different. Incidentally, the history of smoking was more significant than the laparoscopic partial nephrectomy group, and the history of hypertension was more common with the renal cryoablation. Table 2 is the disease characteristics. The mean tumor size in the laparoscopic partial group was 2.7 centimeters compared to 2.9 centimeters and 2.6 centimeters in the renal cryo group. No significant difference. In terms of the tumor location, also no significant difference. However, if the tumor was to abut collecting system, the choice was to go ahead and proceed with laparoscopic partial nephrectomy due to higher risk of urinary fistulas and complications after cryoablation. Our pathology, and there's a typo in our abstract, our actual renal cell carcinoma was found 82% in our laparoscopic partial nephrectomy group compared to 63% in the renal cryo group. Benign histology was 17% and 15%. The tumor was not identified. There were no cases. All tumors were identified in the laparoscopic partial nephrectomy group. However, close to 21.8% of our patients in the renal cryo group we could not identify our pathology. Our mean follow-up was 23 months for laparoscopic partial nephrectomy and 29 months for renal cryo group. Positive margins were 0 in a laparoscopic partial nephrectomy group versus 6.7 in a renal cryo. 8 patients, when we followed them, they did have residual disease after the procedure, and they went ahead and underwent repeat salvage cryoablation of the positive enhancing lesion. And disease-free survival, 99% with 1 local recurrence for the laparoscopic partial nephrectomy group compared to 97% with 4 did have disease, eventually a renal cryo group at our follow-up. However, overall survival is still essentially similar, 96% versus 97% at our follow-up. So in conclusion, we conclude from our retrospective review that the intermediate oncologic outcomes, overall survival and disease-specific survival, appear to be nearly equivalent at this stage in our multi-center review. However, in terms of treatment failures and the need for repeat treatments, and cryoablation was more prevalent statistically. And however, while further follow-up is needed to further evaluate these patients when they return to our clinics in the future, we still exert a lot of caution when we recommend cryoablation, especially for young, healthy individuals or for those patients with more than 4 centimeters on masses. And I have nothing to disclose. Thank you.